Thank you everyone for coming. This is our second pitch event. We've done the first one in February. Now we're the second one in healthcare today, and after we move to the next one in impact next month. So today we have 9 great founders pitching their ideas, their startup. Someone in more early stage, others in more advanced stage. So I will start introducing Bruno Montanari, which is our first panelist, waiting for that to come in help very soon. Bruno, please.
So yes, very briefly, hello everyone. I'm a partner at Ceroba Life Sciences, which is a Dublin-based early stage VC fund. We invest both in biotech and medtech, usually lead or co-lead, and very happy to be there to hear about those great stories, innovation, and people.
Thank you, Bruno. Now, the second is Stephanie Tumba and Catello Soma. They are coming soon. So we are not going to wait because we need to move forward. So we move with introducing our great founders. We have 9 of them. And what I'm going to do now, I'm going to call one after the other. They will pitch to you, and we have some Q&A after the pitching. For now, with Bruno, and after, hopefully, Catello and Stefano will join us soon. How we are going to run this pitch session, after the pitch, 5 minutes pitch for each founder, we have another 5 minutes Q&A with the panelists, and we start collecting also questions from the attendees, and at the end, at only end, we leave the last 20 minutes. We have our pitch day up to 7 o'clock, and from the attendees we can take some questions and asking to the our founders. Now, I would like to start with our first founder, Ina Burgstaller, CEO and founder of Bionabo TM. Ina, please, the stage is yours.
Thank you very much. So we'll start sharing my screen. My name is Ina Burgstaller. I'm founder and CEO of Bionabo. It's the place where the ideas, bright ideas in health tech can be turned into reality. We're doing so by connecting brilliant people and companies together. Now, why now? COVID-19 has accelerated global healthcare innovation. We all know that. But entrepreneurs and companies need now fast-track formation of teams and partnership, which is very much needed to deliver results and return for investors. So the problem is that 86% of healthcare projects are mostly the failure. It's not because they're bad ideas, but because company can find the right support and partners to bring their ideas to life. So what are we missing? How can we change that? The problem is quite complex for the healthcare industry. If we look into the health tech entrepreneurs and the startups, it's really hard for them to navigate heavily regulated and fast-moving sector. They don't know where to find high-quality help and how to get support for this. If you're a service provider expert, these guys have great skills and they know how to turn bright ideas into reality. But to find very good startups and well-paid opportunity is a challenge. And finally, pharma and larger health and medtech companies, they really want to de-risk their health tech investments, and they're looking for high-quality, smaller companies that they're ready to go for them either to partner with or merge. So what is the solution? Bionabo. We created matchmaking platform for entrepreneurs, companies, and service providers specifically dedicated for health, medtech, and biotech sector. Bionabo is the place where health tech, medtech, and biotech companies can not only find support and partners to support them at every step of their journey from bright ideas, but also partner and complete the M&A deals. So whom we help? We have companies to quickly get access to the validated niche service providers, provide them with virtual project management support, and reduce their project management costs dramatically. For service providers, we help them to make their sales more efficient so these guys can focus to do what they do well. And for larger pharma and medtech, we provide them opportunity and access to the community of brilliant entrepreneurs and experts, which de-risk their partnership and return of investments. So let's look at Bionabo in action. Likarna Online is our case study. This is the biggest mHealth program for Ukrainian refugees worldwide right now. And this demonstrates how powerful our community is. Within 2 weeks, we onboarded 147 doctors, and over 100 patients have been already served by providing them medical triage and telehealth consultation. And this is only within 2 weeks, all done on Bionabo. We do due diligence, doctor-to-doctor consultations, and case matching by providing them with a really good opportunity for our booking team to match them with the right doctor. So our early users love Bionabo already, and I'm so pleased to see already 2 of our Bionabo members here in this call. Our advantage is unique. Yes, we are one of the first to market innovative crowd teaming solution dedicated to innovation and healthcare. We have close competitors, BioVis and AngelMD, but these guys do matchmaking and do not focus on project delivery. So our unique advantage is quality at every step. How we do that? This is a mechanism behind. We handpick experts, service providers, and relevant companies working in the respective sectors. We do run events to support the community, growth labs to share expertise, Dragons Den to make competitive events to find best from the best, and showcases for medtech students or pharmaceutical company to find these companies. So what we are doing, we are leveraging synergy. And our formula is good plus good is great, but great plus great is amazing. So we create value, and this is our business model. Our main business model is sales commission for the project, which is 5 to 20% depending on the contract value and duration. And this is broking deals for M&A activity, health tech to biopharma matchmaking, and company to investor, and as well as company to the service provider. There are paid events for pharmaceutical showcase and investor showcase, an optional service for project management oversight, risk mitigation, interim CTO, COO, and other senior roles, and business strategy. So the market opportunity is really huge. We are looking at the 12 billion sum, but our serviceable obtainable market is 3% to find the most competent independent professional in their respective field. We are really selective because we focus on quality. So our projected revenue in 5 years equals 37 million. And our marketing plan is based on partnership, traction and validation, and online marketing. We're very proud to announce this week that we are partnering with MTF Cambridge. This is a national medtech network in England, which is promising, very promising, because we are expecting more than 4,000 users just from this network alone. So our leadership is focusing on domain experts with a proven track of record and unique and strong expertise in this field. So the synergy starts from the founder team, domain experts in software management, in project management for the healthcare sector, marketing, and medical expertise. So we're looking for 500K seed investment to expand our technology, which is ready to go to be coded, to introduce project module to enable crowd teaming, payments on the platform, better AI matchmaking, and video consultation. 30% we are planning to invest in sales and marketing, and 20% in operation and community management. So what we are offering is private equity. Right now, we valuated our company 1.5 million. And our exit strategy, medium term, up to 5 years, is M&A, and long term, M&A or larger organizations such as pharmaceutical company in the outsourcing sector. So just a summary, how we turn ideas into reality. One of the first matchmaking platforms dedicated to innovation and healthcare, massive potentially market with expansion opportunity, synergetic effects on bringing great people and matching them with the great ideas, technology-led and scalable business model, and built by the domain expert for purpose. I would be delighted to talk to you if you're interested in this exciting investment opportunity. Thank you.
Thank you, Ina. Thank you very much. Before we move forward with the Q&A, and after you can come back, as I see Catello is with us. Catello, thank you very much for coming. I was wondering losing you. Bruno were the only one, so we hope we have two of you, and we are still waiting for Stephanie. If you want, give a very short introduction yourself, and after we can have some Q&A with Ina if you want.
Happy to, absolutely. This is Catello Somma from TVM Capital out of Munich. This is one of the oldest transatlantic fund. We have $500 million fund number 8 that we closed last year. And we are investing in both therapeutics and medtech digital and diagnostic companies. I'm a molecular biologist by training with an MBA, and after 13 years of experience in the industry, I moved to TVM in January 2020. So nice to meet you, everyone.
Thank you, Catello. Bruno, Catello, if you want to have some questions, we have 5 minutes after any pitch for you to discuss with each of the founders.
So quick question for Ina, 2 questions on my end. The first one is to understand how you qualify those experts. What's the filters? Because usually what's being done in real life is from people's recommendation, those experts are being brought in and are being mandated. So here, with such a platform and the sheer number of experts that will be available, how to make sure that this is not only a good match, but as well that there is qualified experts on the other side of the table.
Sure. So for the experts, for every verified member on Bionable platform, we dedicate half an hour of video consultation where we have an interview of the motivation and how this fits the mission and the Bionable vision. We do the soft check. If this is an academic, we do see if the person has a publication. We do verify the person who was on the call, what the picture they put on the Bionable platform. We're also doing some soft check and seeing if this is matched with what is on LinkedIn, if this on LinkedIn is available. For the Likarnia project right now, we are currently running, we have a dedicated due diligence team on the Bionable platform where we have fast track where the doctor is uploading their medical licenses. These doctors are worldwide. We have turnaround time for every verified doctor, 2 to 3 working days. We are also releasing a liability form to participate in this project, and this is very robust. And our team is knowledgeable to read the medical licenses, even in Hebrew.
So when it comes down to advisors, interim management, you're doing reference check as well, like a headhunter would do?
Yes, we do. We have a third-party providers, which are advising bank industry. This is an additional service. So if this comes to the very senior role, it goes to the third-party provider, and they do the full due diligence check on them.
Okay. And the last question I had, because I'm not sure we have lots of time given the number of presentation, is to understand the comparable deals. You mentioned M&A exit, but based on what metrics and what has been the deals over the last years with this type of business?
Mm-hmm. Sure. We have right now we have a great demand on companies to be matched with pharmaceutical companies, and they're looking either with the licensing agreements or extending the patent application. So we are currently matching For example, Migraine app, we are matching them with pharmaceutical company who are in the process of kick off the clinical trial in the same indication in order for them to match together and run the clinical trial as a drug device.
Okay.
Bruno, we have 5 minutes, more or less, but even in 5, 6, that's not the problem.
No, but that's fine. I don't want to monopolize the discussion.
Catello.
How you see the kind of economy of scale for this business model, right? Because you say that you engage the provider, right? But this could be human intensive kind of business, right? And as you can see, can have an impact in your profit and loss. Do you see here ways of improving the structure to increase the marginality, or you see these more a kind of cross-selling platform and so on, so that you can really grow your revenue line here?
Yeah, so partnering with Equity Match is one example. For example, we are providing services and Equity Match providing matching with investors. We can leverage our capacity because we provide the more better value for the companies to partner with the right companies who do similar thing, but we are very strong providing expertise plus matching to investors. But as I said before, the smaller deals will be supported by the technology. If somebody providing smaller consultations or regulatory advice, it will be done very similar as with a freelancer platform. So Bionabo is really like Upwork merged with LinkedIn with the project management support which CROs provide. So if we are looking into M&A deals, for example, matching, as I said, we have right now a project right now to be matched with the pharmaceutical company. It needs a little bit more expertise and a bit more detailed matchmaking. But for these companies who are we are curated during our Dragons Den, and they want to be a bit more curated with expertise plus match with investors, we are partnering with our partners, and one of them is Equity Match.
Thanks.
Thank you, Ina. Thank you very much. Please stay because we take some Q&A at the end, if we have some, I hope so. But for everyone who wants to ask, please ask on the Q&A bottom, and also when we finish, we edit the video, we send the video to everyone as well. So we publish the video on Equity Match LinkedIn as well. So now, let me introduce the second founder, Rehan Huda. I hope it's very complicated to pronounce all the name perfectly well because everyone is coming from a different geography. Board member of My Next Health Inc. Ruan, please, the stage is yours.
Okay, so thank you very much, Matt, for setting up this excellent session. My Next Health is next generation genomics company, which has, we believe, some of the most interesting technologies related to this industry. As some of you may have read, they're thinking that the next revolution for humanity is this genomics revolution. We had the computer revolution that has changed industry over the last several decades, and we believe the genomic revolution with the advent of the Human Genome Project will cure many diseases, lead to longer lives, better health, etc. However, since the last 20 years, when the Human Genome Project was completed, we're seeing a lot of challenges. Although there's an enormous amount of data, although so much research, AI, machine learning has been put to it, they're not getting the amount of results that they thought. Billions have been spent on the project, hundreds of billions of dollars in market capitalization through companies working on genomic research, and the return on investment has been underwhelming. And we're seeing that the gene therapy approach, looking at one gene to one disease condition, is only leading to small outcomes. Mind you, some very interesting breakthroughs, such as Huntington's disease, such as sickle cell anemia. However, we believe that there is enormous untapped data that's out there, and we just need to understand it better. And this is where My Next Health Genomics has come into play. where we see companies like 23andMe and others getting an enormous amount of data from consumer research. My Next Health, led by Dr. Mansoor Mohammed, who's considered one of the leading geneticists in the world. His research work twice has been shortlisted for a Nobel Prize in Medicine, did the breakthrough work in cancer and genomics, was one of the discoverers of copy number variation, and was a CEO of one of the first genomic companies out of NASDAQ from Baylor College. He spent the last 5 years with 10,000 case studies, interviewing each patient, something a geneticist rarely does, look at patients, and looking at pathways, interrelationships between genes themselves as well as the environment. And it's been a breakthrough, a whole new way of looking at genomics. And the way we've looked at it is the genes are basically the verbs of the human body, and DNA is a language. And we believe we have decoded the language of DNA. And we're putting this all together in AI machine learning engine. We've brought on Sudhir Saxena, who's considered one of the pioneers of AI. He sold his first AI healthcare company in 2003. He pioneered Watson's AI, led the business development and solutions since 2015, and went into retirement. We got him out of retirement, and he has constructed an AI machine learning platform that will take all of our insights, use structured and unstructured AI in it. In terms of the business applications of this platform, one is clinical trials. We believe we have unique insights, and we're calling our platform JEDI, Genomics Empowered Digital Identity, where we will be able to take all the data that's out there in medical journals, etc., with our unique insights. So we've discovered basically about 200 unique relationships between genes and the environment, which we believe will determine human health in many, many cases, the root causes of most inflammatory related diseases. And one business line is clinical trials. We were just selected from National Football League here in the United States. There were 106 applicants, top research groups, pharma groups, etc. They chose 2 for clinical trials on concussion and chronic pain. And we are one of the 2 selected. Our group was press released at the time of the Super Bowl. We have healthcare providers now that have struggled with a number of disease conditions that are costing them enormous amount of money. We're doing clinical trials, preparing them on diabetes, fibromyalgia, etc. Then we had press release with a public company recently, a unique clinical trial on wound care and stem cells with a Canadian public company, and we have some unique patents with stem cells and genomics that we're putting together. We think this is a tremendous business line. Not only are we consulting with clinical trials, but we have our own unique clinical trials. We have some breakthroughs. We believe we've cracked the code on why autism has dramatically increased over the last 20 years. We have some relationships in breast cancers. We've identified linkages to certain birth control pills. We've also identified some unique causes and potential therapies in areas of prostate cancer, hypertension, etc. Another business line which we'll have are clinics. We're planning to build our own clinic in Princeton, New Jersey, with Dr. Mansoor as being chief geneticist there. Right now, and for the last decade, he's been consulting with some of the top healthcare genomic-based clinics, and we are now going to be opening our own, and plus our software and platform can also be used as a plug-in into other clinics and hospital systems as well. This is the revenue forecast over the next several years, and the various different business lines that we have. This is our EBITDA forecast over the next 5 years. In terms of our team, Dr. Richard Heinzel is our Chief Executive Officer, Harvard Oxford trained global healthcare specialist. Early in his career, he was the founder of Doctors Without Borders in North America, was instrumental in them winning Nobel Peace Prize. Over the last number of years, he was with Harvard and Oxford and Mayo Clinic, working on digital health platforms. Dr. David Leeper is our Chief Medical Officer, and Dr. Mansoor is our world famous geneticist, and Sudhir is the gentleman who came out of retirement for leading our AI machine learning services. Rudy Mazacci is Executive Chairman, who was twice Global Entrepreneur of the Year in biotech. Very experienced in taking over a dozen companies to IPOs and M&As. Myself, General Wesley Clark, who former commander of NATO, ran for the Democratic leadership presidential candidate twice. Very active in the biotech space, and we're right now looking at a PTSD clinical trial with the U.S. military. And these are our advisors. Dave Johnson was the former senior managing partner at Blackstone with their tech fund, and we've got a Bernie Rice, IBM, and also another IBM gentleman who are advising us primarily on our technical and business development. We have a convertible note offering, $5 million, 1 year, 12%, converts at a 25% discount to next equity round, plus a full warrant. And then we had got a cash kicker where half of our first 10 million in revenues goes back. So we believe this is a very attractive offering. And this is our final slide, my contact information. Thank you.
Thank you, Leon. Thank you very much. I will leave you to Bruno and Catello.
So I will start with just one comment, which is a perception. You seems to have different business and business models in one. So might not be able to track, but a key fundamental question for me to try to understand what you're doing is how you validate such an approach. I've been hearing about trials, about clinics, but at the end of the day, what's the validation that your technology brings something?
Yeah, that's an excellent question. In terms of the insights that we have, the 200 insights, over the 10,000 case studies we've done have all been validated through about 4,000 peer-reviewed journal papers. And so the insights we have are relationships between genes and the environment, a relationship between genes and others. What Dr. Mansour has done is put it all together. So we're not creating any sort of new insights on the genes because so much genetic research is out there. The missing link was how these genes work together. And that's really the key IP that's come out of our clinical work with McGill University, with the lab, the Canadian government, and the 10,000 case studies. And so that's the IP. And we're just applying this foundational knowledge to clinical trials, applying it to our own clinics, etc. And so it's really
concretely, what is coming out of this?
What is coming out of it is a new approach looking at diagnostics and therapeutics. In the future, before you take any therapeutics, you would have to go through, and it's starting now, but not at the depth that we're bringing to the table. You'll have to go through our genomic engine to get the most precise genomic understanding and have much more precise therapeutics as a result.
Okay. One question here, if Bruno, you don't have other points here. So in fact,
no, please go ahead.
Okay. We see several attempts, I mean, since almost a decade, right, of using these omics data to drive better treatments or, predict responses and so on, right? Super valuable. And we are going that direction. Not sure if we are exactly there at the moment. So for sure, I appreciate that you are playing in that field. On the other end, in terms of validation that is related to what Bruno said, are you running studies, right, with biomarkers and so on, so that you can have a kind of a head-to-head comparison, right, or against, historical data that you find out of publication and so on that can really show that you are, more sensitive, more reliable, more precise, or you can really predict, in fact, what you promise to do, right, with your modeling?
Yeah, no, that's an excellent question. Now, we are running studies. For example, we believe we have cracked the code on why autism has dramatically increased over the last 20 years. We have the theoretical aspect of it on the genomic side, which is which is known. We have the environmental factors, which we have identified, which is known. And then with one of the hospital systems here, we're just running the data, and we'll be linking, we believe, the increase, 80% at least, explanation of the increase in autism over the last 20 years through a change in prenatal supplement that we believe is a cause of neurologic inflammation. And the data all seems to support it. Our theoretical foundations support it. And of course, we will validate this through clinical trials. And so these are the type of things. When we won the National Football League clinical trial, we had a very strong theoretical foundation behind our understanding of pathways to neurological pain, our pathways through concussion, and then the therapeutics that are out there will obviously need to go through a clinical trial and FDA approvals and that. So what's different is the 10,000 case studies were in fact like a dozen clinical trials. That work we did, which is our proprietary data, have shown relationships on how genes interact with each other and how they interact with the diet, the environment, etc. And that type of research has not been done before. These relationships that are foundational, we believe, explain 80% of most disease conditions. And you need to understand those. And so that's what makes it very unique, this type of platform.
Thank you.
As we have 1 more minute, I can take one question from the attendees. Dr. Nicolaus Nelson, is the team using only secondary data, or are they creating new data sets as well?
We're using our own data. There's data that's out there with the NIH in the US, hundreds of thousands of complete human genome data that's used for research purposes. But we have our own proprietary data as well, which we have generated. And so we're using both.
Thank you. Thank you, Ryan.
Thank you. Thank you much.
Let me move to our third founder, Jim West, CEO and founder of Clara Biotech. Jim, please, the stage is yours.
So today I'm going to talk to you about an exciting new area in biotechnology centered around exosomes. I'm going to tell you what they are, why they're important, and why Clara Biotech plays a role in this burgeoning industry with our platform technology. Clara Biotech is building a groundbreaking exosome isolation platform that's going to enable the next generation of biotechnology and medicine. My name is Jim West, CEO and co-founder, and if you haven't heard of them before, exosomes are the FedEx delivery system of the body. They're made by all cells, human, plant, and animal, and they represent an exciting pathway for an emerging range of medical breakthroughs, like developing really precise diagnostics for a large range of diseases, like cancer and Alzheimer's disease from a small blood sample, for example, to new ways to deliver drugs to specific locations in the body. And this is really important because the methods today have big problems with toxicity, targeting, and other side effects. In addition to these exciting areas, exosomes made from stem cells also help to reduce inflammation and promote regeneration, and are now thought to be the active ingredient in stem cell regenerative medicines. Exosomes are going to enable a renaissance in liquid biopsy, precision medicine, and drug delivery. And the problem is that today, exosomes are isolated from any solution in a bulk method like size or density filtration, which has a lot of impurities and contaminants that you don't want and can't get rid of. These current methods are difficult, highly impure, and difficult to scale. This leads to problems for pharmaceutical companies that want to use exosomes in drug products. They're not able to manufacture them because they can't get pure product. And if they can't get a pure product, they can't actually get the drug approved by regulatory agencies or detect the biomarkers that they're looking for. If exosomes are the FedEx delivery system of the body, then Clara is the parcel sorting system. And I'm proud to have a unique, scalable, breakthrough platform that meets the needs of this industry like nobody else. So the way our product works as a solution to this market is through a selective, high-quality isolation platform that's able to isolate exosomes exclusively. We'll enable companies to get their products to market because they're going to be able to manufacture a pure, high-quality end product. For diagnostic purposes, we help them get to signals that they're looking for. In a nutshell, we're providing pick access to miners. We don't know who's going to win, but they're going to be using our technology when they do. And the way our process works is you take our bead reagent and you mix it with your sample, which binds exosomes to the surface. You put it into the tool here in panel 2, and within 15 minutes, you have exosomes separated from your solution. It's that simple. And in the future, we're going to automate this entire process. As an example of what this really means, one of our early customers is Dr. May Mahoney. She runs a lab at Thomas Jefferson University in Philadelphia, and we've helped her to get exosomes that have enabled her to identify both the presence and stage of cancer in patients. This data was presented at a recent conference, and we've helped her and others to enrich for biomarkers they were not able to detect previously. We're in an exciting and fast-growing field with an addressable market greater than $1.5 billion. And recently, there have been 5 $1 billion licensing deals with exosome manufacturers using old isolation technology with a difficult path to market. We have the potential to work with and help all of these companies. And in fact, we might be working with some of them today. We are moving to market in the next few months our first product, a research use only exosome isolation kit that can be used in any laboratory, and we have more than 10 early paying customers. This is a reusable tool and a single-use consumable, which will lay the groundwork as we expand and grow to help companies get their exosome-based products from the bench to the bedside. We finished our seed round last year for more than $1.5 million and have had more than $2.3 million in full funding to date. We are preparing for our Series A later this year. We're moving our first product in the coming months, and in the future, we'll be expanding the product lines in a variety of ways, including supporting manufacturing for clinical uses that meet the needs of regulatory bodies. We have an amazing team with a diverse background in exosomes, drug and diagnostic development, and scale-up manufacturing. We have 7 full-time staff, and we're hiring. And one more thing, we have additional benefits like subtyping I haven't had time to cover. This isn't about treating one disease or condition. This is about building a platform that will solve isolation challenges for all and help to bring exosome technologies to the world. I ask for your support on this journey, and if you'd like to know more, please reach out to me after. Thank you.
Thank you very much. I will let you with Bruno and Catello.
Catello, you want to start?
Yeah, I mean, just a quick question, because exosomes now is a field with increased interest since a while, but one of the key items is, okay, how you protect, the patentability of the approach. Could you elaborate on your strategy?
Yeah, great question. So my co-founder was a professor at the University of Kansas in America, where this was developed. And through that, we have an exclusive worldwide IP rights license agreement. We have 4 approved patents to date, and we have more in development around the key IP of our bead manufacturing, as well as the mechanism of capture and release of the exosomes.
And are these exosomes, let's say, manufactured in Kansas, in academia at the moment?
Yeah, so to be clear, Clara doesn't manufacture exosomes. We manufacture products that let people isolate, and to that, yes, we do all the manufacturing in Kansas.
For the okay, thanks.
And so is it about isolation of exosomes, or is it as well about characterization of exosomes?
For us, it's really about the isolation and purification, although characterization is enabled because of what we're able to provide as a product.
Okay, and so just coming back on this key feature, isolation, how are those companies, Evox and the like, doing it today?
Mm-hmm. So the companies, especially at the therapeutic scale, they're generally using some form of size or density filtration, or a combination thereof. So it's usually proprietary, but they're doing size exclusion chromatography or tangential flow filtration. And the problem is that these things are about 100 to 200 nanometers in diameter, and you just get a lot of contaminants that are non-exosomal and non-quantifiable in nature. So at the end of the day, people don't know how potent their product is. They don't know the true amount of exosomes that they have in their solution.
Okay, i.e. they cannot have a real drug candidate unless they can.
Yeah, and there's definitely
and they can have
lots
batch
of
to
products
batch. Reliability. Okay, so this is what you bring. And obviously you're dependent upon those companies to move forward and new companies to be created. How do you see the field right now between therapeutics and diagnostics here? Are there a stumbling block, and actually will you facilitate the life of those companies to move into further clinical trials and having less of a production and CMC issues? Or you're totally relying upon them, and if there are not that many at the end of the day, your customer base is going to be short?
Great question. We really have three major customer segments as we see it. There's sort of the academic and research space, there's diagnostic biomarkers, and then there's therapeutic use manufacturing. And we're working through that in that stepwise manner. We're targeting research use only today, and we're building data and developing quality for the future to then support the lowest hanging fruit right now, which is diagnostics. And we're working our ways towards the data and the information and the quality and the scale to support eventually therapeutics.
Okay.
I have one question along the same line here. How many generations of your system will be needed in order to unlock the full potential of your platform?
So today we're working on small scale stability manufacturing. So we get the same quality product each time. And that's really on the reagent chemical side. There's really two parts to that scale up. One is being able to provide enough of the material reagent. The other one is being able to do large scale mixing and separation with that material. We're focused on the first part today, and that's really the focus of this year is to get us to the scale we need to produce large amounts to be able to start handling liters of material. And it'll be the next 2 to 3 years that we will really work on the scalability of the processing and separation.
Okay.
Thank you so much, Jim. Thank you.
All right. Thank you, everybody.
Now let's move to the next founder, Samit Biswas, CEO and founder of Hippo Mobility Transportation Service Ltd. Samit.
So good afternoon, everyone. I believe most of us keep hearing that a blind person has been dropped in a wrong location by a taxi hailing app, or somebody has been refused for a transportation due to the size of their wheelchair. As per the World Bank, globally there are almost 1.5 billion disabled registered, and out of these in US we have 57 million people who are disabled, in Canada 5.3 million, and UK 15 million. Not only that, there are people who have a medical short-term mobility issue with dialysis, chemotherapy, or knee or hip replacement. But unfortunately, none of them have a dedicated standardized solution for transportation for the specialized treatment. My name is Samit Biswas. I'm the founder and CEO of CareSafe Mobility. CareSafe Mobility is targeting the market. It was a huge, if you talk about only B2B insurance market, it is almost $220 billion market. If you talk about the hospital discharge, is almost $16.1 billion market. But our main target for the time being is B2C, that is disabled population. So out of 1.5 billion, our addressable market that we're targeting is 2.9 million population. And in short-term medical condition, we are targeting around 750,000 people. So what CareSafe Mobility offers? The CareSafe Mobility is bridging gap between ambulance and taxi services by providing a technology-driven, dedicated, hygienic, convenient, safe, and cost-effective transportation for disabled people, elderly people, and non-emergency patients. From the diagram, you can understand that what exactly you're trying to achieve with the technology. We call it digital safeguarding technology. What it offers live transmission under 5G and 4G data with remote medical monitoring, the basic health stat like body temperature, ECG, pulse, oxygen saturation, etc. So how it happens? So technically they can book as of now, either website, we have online booking platform, or they can call us the free phone. We're also launching our own app for both B2C and B2B market. And after that, we have a very important step, that is risk assessment, because we all know these are very specialized people. They're not like a normal people. So we need to understand the need, their size of wheelchair, the location they're living in, whether they are in apartments or house, semi-detached, detached, number of stairs, lifts, all those things. After that, we send them a quotation. These all are automated. Once they're happy, then they accept it, and then the vehicle arrives. Once we take the patients on, the transmission started. And all our vehicles are basically backloaded, where the wheelchair can be placed inside the middle of the vehicle. So they never feel isolated or like, somebody sitting like in baggage compartment. And upon arrival, we ask for the feedback, and then again the whole journey process continue. During this process, if any medical emergency happens, because all our drivers are medically trained, we have onboard oxygen and everything. If they try to manage, if they cannot manage with the existing support and resources, they will escalate to the emergency, either 999 in UK or 911 in US and Canada. So this is the whole digitized journey. If, as I said, like in B2B, we try to do a 2 extra step for the care manager or transport manager, at the same time a transport supervisor or hospital administration, where they can have the additional access for the whole journey. Otherwise, from end to end, we offer whole digitized and safeguarding solution. So in terms of competition, we are the only one that offers technology, transportation service under one platform. You can see some of the major names are there here. Either they are offering highest level technology without any training or medical support, or the vehicle are standardized. So we are the only one that offers live CCTV streaming, remote GPS monitoring, medical monitoring. At the same time, a first turnaround time. Within 45 minutes, our vehicle is there to take them back home or for their medical appointments. So in terms of engagement, as of now, we are operating mainly in the UK. We have around 6 active contracts that offers around 5.5 million. But because of our lack of resources, we're not able to support these full contracts. It is from NHS, Ealing, Bromley, Essex County Council, a couple of other local authorities. Technically, we're doing 3 rides a day with a minimum earning around £297 per ride. And we're trying to achieve around 15-20 rides with our existing 5 vehicles. We have just opened an office in Louisville because it's a hub of the healthcare market, and all insurance companies, big care companies are based in Louisville. We're also exploring the Canadian market, so the whole North America can be covered with one market. So this is our post-pandemic. So what happened, as I said, our target audience is only the elderly and disabled people. So due to pandemic, they're not allowed to go out. So we lost our revenue heavily. But again, after the market slowly started opening up, we have gone up. So this year we'll be closing on £125,000 in total from March last year, April last year till March this year. So typical, you can see the ride quality is around £70. If it's an ambulance or stretcher vehicle, it's £350. If we add additional services, so we charge another £150. We also have a couple of small contracts that are around £28,000 on an average, and lifetime value of our clients, which we have few in our customer list, around £5,000. So this was the whole journey. We started back in 2019, and so in 2020 went up. Then again in pandemic it went down, and this year we are again closing £125,000. So if we not get anything with the existing resources, we will be closing around £1 million revenue in next financial year. So this was the impact. So as of now, we are getting around 30,000 visitors every month on our website with the 500 calls. We have done around 5,371 rides for non-emergency patient till February. And we have not taken the March figure yet. Our Trustpilot score is 4.3. We have achieved around 5,000 NHS appointment with us. We created 14 jobs in the local economy, local market. And just to offset our carbon footprint, we contribute 0.1% of our revenue under Strive Climate Change. So in terms of team, it's a very small team. Me and my wife and Jaita. Jaita looks after the compliance part. She was a part of Babylon, which is a UK unicorn, now recently launched in the US. She has around 15 years of healthcare expertise. Personally, myself, I have almost 30 years of working experience in J&J, Zimmer, Smith & Nephew, Medtronic. My wife, Ratna, who has a huge experience in healthcare and insurance market. We also have Bipin, who is based in Chennai. Now we are moving him to UK for the full time. As of now, he was working part-time. We have Bibi, who manages our HR and finance, and Rebecca, who is again a part-time non-executive director, helping us on the operation side. So this was the model looks like for the future. You can see the generation 1, it will be just live streaming with remote medical monitoring. And in generation 3, we'll try to do a two-way communication. It means somebody, when we're taking them in a traffic, they got stuck and they started getting panic, the palpitation. So that time, either the family member or carer can directly talk to them through the mobile app so that they can reassure them. so that they can come down. And ultimately, we are planning to launch a generation 4 AI-driven predictive analysis, so we can predict the whole journey and looking into how the chances the person can fall sick while you're transporting them. At the same time, we're also, with our existing customer base, we're trying to launch a home-based healthcare support that will be in either phase 2 and phase 3 model. Sorry. So we are raising around £3 million seed funding. Minimum requirement is £250,000. We also have a UK EIS, that is the Enterprise Investment Scheme, approved by the government. The whole spending, it will be around 30% spending on the team building. As I said, we have a very small team, around 14 members, but we now need to grow globally and make a presence. We need to really build the professional team. That is the most of the money we'll be spending. Then 27% is spending on the technology part. Around 23% will be spending on the marketing, 13% on vehicle, because vehicle is not our core area of business. We won't be managing 10,000, 15,000 vehicles all over the world. It will be a hybrid model. So every market, it will be 5-10 vehicles managed by us. Rest of the vehicle will be from the local supplier, where we will be giving them the technology and training so they can support our business. They'll be working as a subcontractor with us. So this is a snapshot, looks like as of today. So we have done almost £600,000 revenue in total. We are expecting a 5x return by 7 years because the market is too huge and there's a huge need for the services, because we keep on getting option from the care homes, local authorities, NHS to move their elderly or the adult social care market. So the demands are very, very high.
Tommy, stay in the 5 minutes, please.
Yeah, it's done. So this is a journey that we started back in 2010, and now we are moving to US and Canada in 2021. And so any question, I'll be happy to answer.
Thank you, Samit. Bruno, if you want to take the first one.
So I'm hearing B2B2C, B2B, B2C. I mean, it's really different business models, different approaches. I'm not too much of a believer that one can do it all properly. And the second thing is you're approaching different geographical markets. While maybe I'm too dogmatic on that, but I would have sensed that you should choose your own home market first, go deep into it, understand the drivers, and then once you succeed, maybe think about how to adapt or get your model adopted in another country. So how do you view this?
So you're right, and exactly that was the whole model. So what we have done in last 3-4 years, we try to build the model, make sure we have everything in working condition. We tick box everything, compliance, paying customer. That is the reason we have almost £600,000 in total sale. And US is basically a market driven. It's a number of people there. The demand is very, very high. That's the reason we are targeting US market. So we have seen the market is operating here. And the reason we say B2B and B2C, because in UK, it's completely B2B market. Here, the payers are the NHS, local authorities. We have only 10-20% revenue coming from the direct patient or some insurance companies. Whereas in US, completely, it's a insurance-driven market. So that is why we're targeting both the segment. And exactly that is the whole idea. So we tried the product in the market in UK, which is completely regulated. We're performing well. And now we are expanding in US market, where we have the higher customer, higher number of paying capacity, and more business.
Okay, if I may, another question. I mean, I saw the increase in terms of revenue per customer, but how does it compare with your direct competitors that you mentioned on the slide? Are you more expensive, less expensive?
No, we are 1/7 of the ambulance cost. So ambulance-wise, we're 1/7, almost 70% cheaper than ambulance, and 20% cheaper than normal taxi services. And that is where we say we are creating a third care pathway, which is neither a taxi nor an ambulance. We are in between.
Okay, thank you.
To that point, do you think that these are your direct competitors? Because as you know, there are a lot of NGOs that in fact are using these small funds, right? And also for free to serve your same customers, right? That's the first. And the second is assuming that you are driving a kind of a technological transformation here. I mean, it's a Uberization, in fact, right? This is what you're following here. In fact, do you think that it's better to be vertically integrated, right? I'm not talking about B2B, B2C, the business model here, the customers, the sales, but in fact, what you have in your value chain, right? Because you have the software, you have the telemedicine, right? You have the leasing. So you are intensive in using people, right? The drivers, you have to train them, you have to track them, you have to incentivize them, right? I mean, do you think that it's better to be a one-stop shop or to go more on the kind of strategic partnership kind of approach?
No, I think I have missed that point. I categorically mentioned that every market, the model we are creating hybrid model, because as you said that there are some local charities that they are offering services. Even we have done studies in Austin, Chicago, and those market, and we see that the chance of getting those kind of rides is very, very minimal, because they might be having one vehicle that covers the entire community. So if suddenly a wheelchair person had a fall and they need to go to a doctor or they have a medical appointment, sometimes they don't get it. So one point is there, so they are not our direct competition. So the demand is so high, we still have those market. Second term, in terms of integration, as you rightly pointed out, we won't be having like 5,000 vehicle, 10,000 vehicle in any given time. Our whole model is every market. For example, right now in London, we have only 5 vehicles and we have 75 other aggregator in the platform, those who support our business. So the whole model is to give the technology and training. And that's the reason in US, the good thing, we're getting a lot of attraction from the local authorities like Philadelphia, Jacksonville, Fairfax. They are very much interested because they could see that we can cut down the unemployment problem there. So they are saying, we'll fund the vehicle for the local unemployed youth. You give them training and technology. So the community will be served. If you go to Michigan in Flint, there is absolutely nothing. For a normal butcher shop, they travel 4 hours to go to a butcher shop. And if they're in wheelchair, things are very difficult. So that is the model we want to build out. So it will be an Uber-like model, but in a hybrid, because it's a healthcare. For any reason, if there is any issue, we have to have the backup. And that is the reason we are building this way. The one-point shop with a strategic local partner to kill competition.
Thank you.
Thank you.
Thank you.
Let's go to the next one. Georgi Nacho, CEO of Beachborn App. Georgi, please, the stage is yours.
So good evening, everyone, or good day, depending on your time zone. My name is Georgi, and I'm here to share something big. Namely, in 2021, over half of world's population indicated being partially or constantly burnt out. I'll hold my presentation as short as possible so that we have more time for discussion. So coming back to the statistics, those 50% of burnout rate are only last year, long before we account for this year's COVID and geopolitical tensions. Hence, expectedly, the rates will continue to rise further. To spare everybody's time and cut the chase, I'll be very short. We are a team of over 10 people spent across 3 countries, united around the mission to solve burnout globally. We've been working on the world's first holistic personalized digital burnout therapy over the last 2 years. What makes us special, or what sets the therapy apart, is the fact that it's patient-centric and holistic, 100% human machine driven, so anonymous without any stigma. We are planning to go all the way to a digital therapeutic, and mostly it's scalable and 24/7 accessible. Over the last 2 years, we have been bootstrapping, and we managed to do the fundamental development of all our content, also to build the first version of the working app and launch it in November, get numerous feedback, over 150 test cases, and we are just about to launch the second version. Our first pilots are planned to start from May this year. Other curious aspects is the fact that we are starting in a US-based specialized mental health accelerator, and we've actually been inbound approached by Apple and receive regular feedback and support from them in order to make our product even better for their needs and market. The problem is huge. Basically, everybody's burning out right now, and it's it causes both a very high personal cost for the individuals who burn out, but also it's a huge tax on enterprise. So this is more or less clear. What's interesting about us is the two-factor offering that we're combining in one mobile app. On the one hand, we have freely accessible, based on a validated protocol, burnout checkup, which we are making available globally, with the clear aim to support awareness as actually the first needed step in order to overcome burnout. And the second bit is a 3-month-long self-help therapy. What sets it apart is the fact that it's highly holistic. It combines over 6 different schools of thought. It's data-driven. So apart from collecting manual input the data from the user, it also will utilize biomarkers and other health data so that we can enable early on prediction, but also close tracking of the progress. And thirdly and foremost, as one of the biggest issues with burnout, it's absolutely anonymous. So there is no stigma and it's freely available. Just for reference, the typical waiting time in Western European countries is over 8 months from the time where I decide that I need help until I get my first appointment. Along this line, having launched our first and second version of the product, we are right now on the look for €500,000 seed financing with a clear aim to validate the product through the market, expand our presence in the German-speaking region, and start preparing for the clinical protocol. With this, I would like to open the floor for discussion, and I'm eager to get all your most complex questions. Thank you so much.
Thank you very much, Georgi. Catello, if you want to start.
Yeah, so I can tell you that I saw some of these opportunities right over the last period, the last year or so. So that is a positive signal of an increased demand. On the other end, this will lead to some questions on competitions and differentiation, right? As you know, because here the two triggers for the let's say further development and also adoption, right, of your approach rather than the others are first how you can quickly scale up, right, your platform. Second is reimbursability in some geographies, right? We know that we are a bit behind, especially in Europe, and so I would like to have an angle on this point, if you don't mind, right?
Yeah, thanks. Since you raised a couple of points, with which one was the focus? With which one would you like to start?
Well, start with the fast scale up, your go-to market, and how can you quickly catch up on clients, basically, right?
Thanks. So it's a combination between B2C and B2B approach, whereby the B2B part is mainly for representative and positioning purposes. It will be freely available over the App Store starting next month. However, the real focus and the real sales driver and revenue channel is actually B2B clients. We have been speaking with some of them already, both in Bulgaria, where is part of our team, and also starting to speak in Austria and later in the year in Germany. Hence, our main driver for growth are SMEs, insuring companies, and generally digitally driven with digital in their DNA companies. So it is a bit highly B2B focused in terms of distribution. The go-to-market as of now and as of our current stage in development is through pilot projects. So we approach various companies with a clear goal. Okay, right now we have this and this already working, but we are also very clear that it's early stage. So we are eager to onboard and allow for multiple companies to co-innovate with us. And interestingly, the interest has been quite high, especially around the fact that most companies are struggling big time to actually find scalable solutions that can be really accessible, but also overcome the stigma. Now, if we move to your second point of competition and other alternatives, At the moment on the market globally, there are in total 3 slightly comparable solutions, and they're really slightly comparable. You have, you being in Germany probably have stumbled upon the 2 DIGAs that got certified last November. However, they're based on a very, let's say, old school approach and basically digitalizing a rather analog process by putting it into a web browser. What we're doing here on the contrary is basically two things that are different. The first part is the way of checkup and diagnosis, not yet allowed to call it diagnosis, but it will become essentially. So combining lots of different data pieces and really focusing on the early as early as possible spotting of all the toxic processes. And secondly, the holistic approach where we actually say it's all about reconnecting with oneself. In our understanding, burnout is not something super dangerous or so bad and terrible as it's presented. It's all about timing. The big issue is that usually it gets diagnosed very late in the stage, firstly. And secondly, most of the existing solutions, also the lifestyle ones, actually treat symptomatics, but not really the stem reasons or the core reasons for somebody to be burning out. And there is one more company in the US, which is very early stage, hasn't really yet rolled out. But still, we are very happy that so many different players, also the lifestyle ones, are looking in this direction because this firstly helps create the needed awareness on the market. And secondly, the problem with burnout is so huge that we really believe that there is enough market opportunity even to have 3 or 4, even 5 big players only for Europe in order to address it for everybody that is in need right now. So I hope this answers some of your thoughts.
Absolutely. Thank you.
So I was wondering if actually trying to address such a disorder is not going to be a bit of an issue for a digital approach, because you are requiring from those people burnout to take the time to go on the app, to go and have a focus, mental focus on it, go through the entire process, something which will not probably bring immediate positive outcome, takes time to go over that. And so a pure digital solution like that, I'm not sure personally, but it's only a personal opinion, that it's going to be easy, not only in terms of adoption, but in terms of retention of those, I would call them patients somehow. And I'm wondering if when you think about the patient care around such disorder, if you are not going to find yourself in collaboration with specialists for real face-to-face interactions, on top of maybe prescription of some drugs to really achieve a good clinical benefit and outcome for those people.
Cool. I've noted 4 points so far. Thanks for this. So firstly, I want to really stress out, you called it a disorder. We're actually not allowed to do so right now by World Health Organization. It's just a work-related syndrome. So we need to be careful with the terms. But let me maybe compare your alternative. So you raised a couple of very valid points about time, about hesitance, and so on. So if an individual has issues right now, firstly, usually it's discovered quite late in the process or short before hitting the wall, or actually even after that, at the moment where I just quit my job, throw my phone away, I go to the Bahamas for 2 years, maybe I get a divorce and all the other stuff. So firstly, it gets noticed very late in the process. Secondly, it is addressed by psychologists and coaches, but mainly by psychologists. So if we focus on, let's say, Austria and Germany, the average waiting time is 8 months. So today, maybe, this is a huge question mark, I actually have the courage to tell myself, hey, I need help. I call to the ordinary and I get an appointment 8 months down the road. firstly. Secondly, I may not like that person because it's a very subjective matter, one-to-one. It depends on so many things. If I happen to want another one, I need to wait for another 6 to 8 months. Thirdly, it's not really reimbursable. Typically, across DACH region, it's around a quarter, and it really depends what's the specific condition, whether it's actually going to be covered by healthcare insurance. So I don't know if that answers. The alternative, what we've been building is something that's readily available. Even the test is completely free. If I sense that I have any issue, I don't have the stigma of actually speaking with a live person on the other end. Plus, I have it in the convenience of my hands, regardless where I am physically at the moment. With this, I'm moving to the retention bit. This is an important thing. Since, yeah, you're completely right. User acquisition is something very costly. So retention is crucial. And speaking about retention, a funny random fact, people that have burned out once typically carries further the seeds of potentially burning out again down the road. So a very big and important piece of what we've been building here is the so-called Burn Bright community, which starts and is offered both ways as the prevention bit, which we are building right now, but also as post-burnout support. So somebody that has been through the 3-month support is invited to actually keep in the loop and remain in this community where there are different opportunities to keep on taking care with much less commitment and which much less time needed for this. But also rely on early warning system and continuous tracking of my developments in my biomarkers so that I avoid of actually falling into the trap once again. And regarding the time investment, if I come back to your previous question, aside from the waiting time, psychologist visit requires you also, let's say, half an hour, 1 hour traveling time. You have the visitation and so on and so forth. In comparison, what we've been building expects around 3 hours of commitment weekly. This makes around half an hour daily. And it's very intuitive and yeah, pointed towards the inner world and the inner thinking patterns and processes within the individual to actually enable him or her to find their best own answers from deep within. I'm not sure if, am I covering everything? If you have further thoughts,
that's
happy
fine.
to address.
That's fine. Thank you.
Thank you, Georgie. Thank you very much. We move to the next one. Kate Tsui, co-founder, CEO of MedWise AI. Kate, please, the stage is yours.
So great to see everyone here. And I'm Keith, CEO and co-founder of MedWise.ai. And MedWise.ai is the search platform for the healthcare industry. Our mission is to empower every healthcare professional to do their best work and provide better patient care. When I was a medical doctor, just like him, I used to do night shifts. And in the middle of the night at 2 a.m., I'll be super tired, I haven't had dinner, and I have to make decisions for patients. Oftentimes, I'd struggle to find the information I need to make the best decisions for patients. And out of desperation, I'll just Google for answers. And then I'm often frustrated by the results. Turns out I'm not alone. Clinical knowledge is growing rapidly, and clinicians just can't find the information they need to provide best care to patients. 70% of doctors Google at least once a day for professional purposes. However, a systematic review published in JAMA shows that 1 in 2 clinical questions are currently abandoned at the point of care. Without the right information, clinicians are not providing the best care to patients, and this is very costly to the healthcare system. In the NHS, this is estimated to be $5 billion per year, and in the US, $105 billion per year. And at MedWise, we solve this problem by providing a customizable search platform that is specifically designed for healthcare professionals to find information when they're in clinics, in hospitals, where they see patients. And this is actually very timely because telehealth have increased 38-fold, further exacerbating the problem. Imagine if you are an online doctor, you're no longer confined to your local area and will be seeing patients from all across the country. The lack of local knowledge and poor access to local guidance means that more antibiotics will be prescribed wrongly and more patients will be referred inappropriately. Our team have the right mix of clinical and technical experience to succeed. On top of being a medical doctor, I was a management consultant and product manager, and I've sold 1.5 million worth of digital health solutions at Huma, the leading remote patient monitoring company globally. And my co-founder, Luis, was previously founder and CTO at Bloomsbury AI, a question answering search AI startup, which he sold to Facebook. And we have a wonderful team supporting us. So we've already built and launched the product. For clinician, we have a super simple to use interface. They can do a search, filter the sources they like, see answers directly, and in one click, they go to the source for more information. And for organizations, they can customize our search platform according to their needs. They can select the information sources to show to their clinicians, integrate with their local documents, which are not available on Google, and use our data analytics tool to understand the unmet information and education needs of their workforce. So since launch, we've been growing 25% week on week over the past 3 months, reaching more than 2,700 searches this month. And doctors love using our product. These are some of the testimonials showing that they highly praise our product because of the speed and being able to search for everything in just one place. Our business model is B2B SaaS to healthcare and life science organizations, and we have 3 things that we can monetize. The first is our search platform that I've showed you, but actually the engaged users and data insights is a strategic asset that we can have further monetize. So for healthcare organizations, we charge an annual license fee, and for life science organization, also an annual license fee for data insights. The combined total addressable market size is more than 66 billion. So it's a huge opportunity that we're going after. We've signed our first paying, we're going to sign our first paying customer in April, and we're already in 3 NHS pilot sites with multiple organizations in the pipeline. We've also recently won a 310K Innovate UK Smart Grant to further expand our platform from primary care to secondary care. This diverse pipeline shows the flexibility of our search platform and a universal need from clinicians working across multiple settings. Our traditional competitors are publishers like UpToDate, Clinical Key, and Hippocrates, and their product is like a Wikipedia for doctors. They actually exacerbate the problem by creating more content and just pushing it onto the clinicians. They have very low customizability to respond to local needs and a very poor search functionality. We're the first highly customizable search platform tailored for the healthcare industry. We're also supported by very strong advisors and multiple partners in the UK, EU, and in the US. We're currently raising $1 million in equity to match our Innovate UK Smart Grants and also to grow sales in the UK into 300K ARR. We already have 20% of the round committed by our existing investors, and we would love to chat if you're interested and answer any questions. Thank you.
Thank you very much, Kate. I will leave the first one.
Well, I mean, if you want to have a couple of quick questions here. So can you please further characterize what you mean with the great searches as a competitive advantage?
Yeah, so by great search, what we mean, that's a great question, actually. So by great search, what we mean is that we're already proven to save time. Actually, if I can share my screen again. For example, in this case study that is also funded by Innovate UK, we have an independent evaluation by an NHS organization showing that our search compared to all existing solutions is already saving 2.6 minutes per search. So in a healthcare setting, when you have like 10 minutes per consultation, 2.6 minutes is significant. So we are running more pilots, and what we're seeing is that even across multiple disease areas. So this study is only in one disease area. So we have now expanded our search to cover across multiple disease area, and we're consistently saving 1 minute, 1.5 minutes on average per search compared to existing solution.
Okay, thanks. I understand. So I'm not going to challenge these, but I mean, we can talk for hours and dissect your approach and what is in the algorithm. So the other is what is triggering a liquidation event? I mean, you showed the two cases of an M&A plus an IPO, right? I mean, what do you think is needed in order to trigger such event?
Yes, so I think that's quite long term for us. We're still early stage, but for us, we will need to expand to the US market and gain market share in the US as well. So we're starting in the UK, but we're quickly proving the product market fit here. In the US, there is a lot more spend on the data and the user engagement market, which I've shown, which is the 20 and the 40 billion market. So we are looking at being able to penetrate around 10% of the market and unlocking the life science B2B model. And then that could potentially be a good exit opportunity for an M&A. If we are to go further, then we would continue to reach the revenue numbers needed for an IPO.
Thank you.
Thank you, Kate. We move to the next one. Rosanna Jagger, CEO of RIMJ Clinical. Rosanna, please, the stage is yours.
Thank you. Hi, everybody. Actually, a great one for me to follow, because what I'm going to build on is what Dr. Keith has been talking about. And actually, it's about the importance of doctors and clinicians being able to use their mobile phone. So if I take you through a company or our company, so as you can see, .coms is our company. It's very easy to understand. This is a really easy one for everyone to get their mind around. Doctor communications. And this really plays quite heavily onto what Dr. Keith has just been talking about. It has been found that 97% of doctors, nurses, and clinicians own mobile phones. And at present, they're not supposed to have them on them during the ward, or they're not supposed to be using it to communicate, or even doing Google searches. What the NHS and other organisations have tried to do is force them down other routes, so other technology things that things like email, things like using different logins for different systems in the hospital. And what that's stopping at the minute is good patient care. So we have designed a platform that will allow doctors and all medical teams to access for free using their personal device. What does that mean? That means that we are going to empower our workforce, our medical workforce, to be able to use a tool that they always carry on them, irrelevant of whether they're supposed to or not, to speed up and improve the quality of care. So our app is a bespoke medical functionality. It improves patient care because it speeds up the point of care. It speeds up the ability to be able to collaborate with colleagues. It also gives the ability to go into interesting cases and further that medical research. And we have the ability to offer AI algorithms and overlays over images. The problem is really clear. 80% of medical mistakes at the minute are made because of miscommunication. If we just sort of focus on that a little bit for the minute, if people aren't using their mobile phones and are reliant on things like emails, pages, which I think most of the world has accepted is now redundant technology, we can then understand the delays that healthcare workers experience when they're trying to move patient care forward. It causes delays in time, in money, and we waste efficiency. What also happens, and what has been happening, is that 97% of doctors are using those phones to use things like WhatsApp or social messaging to communicate patient details. For anybody in the legal profession or anybody inside of medical data, that should raise huge alarm bells, because what it will do, it flies in the face of GDPR, any type of patient confidentiality, and any type of the ability to use that data again to actually not only justify treatment, investigate what other treatment could take place, but also to be able to let medical teams communicate and discuss that patient treatment. So in summary, it's not secure when they use their mobile phone for any type of messaging. What has also been happening is that people can then leave their phone on the side. They sometimes get their phone back, which is great, but when they leave that phone on the side, their data is not protected. So it means anybody, once they've cracked that phone, can then go in and read WhatsApp messages, social messaging, and has full access to patient details. It flies in the face of GDPR. It causes poor care and communication mistakes. And by this, I mean doctors and nurses are aware they're not supposed to be using these platforms, so they won't identify the patient by name. So what they would do, they would use bed numbers. And as we all know in hospital, bed numbers change. So for example, if a bed number is used to identify a patient and that patient has moved, we have seen circumstances where patients have been given the wrong treatment or blood tests have been taken from the wrong patient, which again wastes time, money, and expertise. One of the main problems we're seeing as well is that the data stream from these very experienced doctors and nurses and these discussions that are taking place on WhatsApp are not administered into the medical record. Therefore, there is no trail of any of these conversations taking place. Therefore, no learning can take place. We're also in the situation where we have problems with communication going forward. We also have problems whereby that medical record cannot be used going forward in a court of law. This solution, we have designed, by use of senior clinicians, we have designed a project whereby all of the details on .coms are safe, they're protected, and they are fully transmittable to anybody in your medical team. It is quick, easy, and cost-effective to use, and we are accredited by the government and the NHS. The value proposition. There are quite a few aspects to .coms. We are not simply trying to just replace WhatsApp. What we are trying to do is create a system where doctors have access to their clinical network, they're preserving the data, and they can get and make sure that those medical records are used in the best possible way. Overall, we're going to improve treatment, and every single person on the planet will benefit from the use of .coms, either directly, unfortunately, or indirectly. If you think about a situation where you've got a relative in a bed, and the reason they're still in pain is because they cannot get hold of the painkillers, you'll find that is not because the team don't want to treat them, but actually the role that doctors and nurses and the communication taking place between them has broken down. Somebody might be forced into an emergency situation, which it happens, certainly in hospitals. But what should also be able to happen is that other teams are able to read the notes on that patient in real time, step in and make sure the patient receive treatment in a timely manner. Just one area I want to highlight before we move on, one area that I haven't yet covered is the revenue streams that .coms creates. What .coms is never going to be doing is charging the individual user to actually access the platform. We are always of the mind that this is a network business, therefore all of the individuals using .coms will be able to use it for free. It is the data in the back end that the institutions will pay for. So a GP surgery will pay a license fee to have the data in the back end uploaded to their medical record system. And that could be an EPR system, an electronic patient record, a healthcare record. .coms is completely interoperable and allows data to transfer through healthcare boundaries. Therefore, this system can be used in the community, in GPs, in hospital situations without any need to change the technology already in place. If we look at why our competitors have failed to deliver and why WhatsApp is still in so much use to date, it's primarily because these platforms have not been designed by doctors and nurses who live and breathe the problem every day. What we've also found is that when they have tried to do something and impose a product on people, certainly these medical professionals, they are time poor. They do not have time to get to learn to use a new piece of technology. Therefore, it has not been readily adopted unless the trust has imposed it on them. And then you only find that single hospitals will use a solution and they cannot talk to anybody outside of that setting. .coms will be completely different. We have already got sign off from the NHS to be used in any institution in the UK, and we are approved and our price sheet has been signed up by the government, so we can be used in local government settings as well. So that includes any institution, Care Quality Commission approved. Therefore, we can include people like dentists, we can include care homes, we can include anybody where that medical record should flow to improve patient care. The market size is pretty huge. We are talking about a type of messaging and creating a clinical network for medicine. The market size in terms of users is 43 million globally, and that equates to a total addressable market of over 6 billion in terms of revenue alone. That is just revenue from license fees. That is not revenue from in-app purchases where doctors and nurses are going to pay to have things like their logbook stored on .coms. So far, we have had 600,000 invested through very experienced technology investors, financial investors, and key medical investors. We are operating in the Fortius Clinic. We operate with UK Motorsport, where their medical teams use .coms to communicate at any sports events. And obviously, we're already in the NHS. In terms of technology ready, we have already rolled out. We're already in the live environment settings, and we are ready to scale. We are now focusing on user engagement and growth. Finally, I want to talk about the data values and the revenues. Our average license fee starts at about £23,000, and that's for a large organisation in the NHS. The price model breaks down and changes slightly differently depending on what the needs are for that institution. We can actually hold and operate data for an institution who doesn't have an electronic patient record, or we can simply input into the existing system. What we expect to happen is the NHS will move quite quickly. Private clinics and other areas then tapping into the NHS will also want to take .coms on to ensure that network and the data flow can stay consistent. The clinical network created, if you look at other case studies where clinical networks have been sold to people like pharmaceutical companies, with 600,000 users would operate at around £45 million. The medical data, and this is a per annum figure, with 600,000 users on the system, we would generate over 36 million data points. And that has a medical equivalent value of 9 billion per annum. And let's not forget, these are not single-use records. This medical data can be analysed and actually used to search for specific diseases to not only further medical research, but also to look at investigating diseases. The experienced team, we have over 100 years between us all. We've got a very small team, but we're ready to scale. We require £750,000 and we've got a company valuation of 7.4. Very briefly, I've marked out how we're going to spend that money, but it's primarily on the staff to resource the business. And that is it.
Thank you very much. Bruno, if you want to start.
One question regarding the time we have left is the following: to what extent you need the institution to push your solution to become exclusive to its medical community to make sure it is fully adopted and used, rather than the docs jumping around from one platform to the others or continuing on WhatsApp, irrespective, because they have been used to this?
Yeah, no, it's a very good question. Very good point. We're talking about behavior and that censoration, not really the technology, but I'll answer it in two ways. We've spent quite a long time testing. We spent 3 years, first one with the prototypes, second year it was sort of doing testing in the live environment, and third has been working with medical focus groups, not only in pilot situations, but also outside of people like places like hospitals and GP surgeries to make sure that the technology works. As we all know, viral growth is probably the only reliable source of telling somebody whether or not this technology is going to work. Whether or not an institution forces doctors and nurses to use .coms is going to be a sort of secondary benefit for us as part of the license fee payment agreement. What we see as most important is that actually our platform is intuitive, easy to use, and actually gives doctors security and peace of mind to be able to use it. What we are also seeing as well is this isn't just a UK problem, this is truly global. So what we're actually seeing is that places like Bahrain, Dubai, we're actually seeing the interest from Singapore and Australia, where what they want to be able to do is connect into the London setting for the research and actually everything about the current pandemic. Had .coms been around sooner, then what we would have found is that, it would have been doctors talking about treatments and pathways and actually improvements and what needed to happen, rather than it having to go through an institution like the World Health Organization. So what we're seeing now is the appetite is not just within the country, but is actually international. And that surprised us a little bit because we thought we would be seeding in the UK and then expanding. So to really answer your question, I think it's going to be twofold. It's not just one or the other. What we're not saying is we're rule either or out. What we are saying is that the technology has been designed for the user to support a viral growth and to sort of be able to support a monopoly growth in that area. But also we work very closely with the institutions to get the license fee arrangement and pay and revenue model up very quickly, just to further that growth. So we get the laggards and the late adopters onto the platform quicker. Does that help?
Yeah, thank you.
Catello, if you want to ask something.
Yeah, I go on a quick one. Do you have to go through a kind of approval committee, audit committee for hospitals?
The quick answer is yes. It always does. It depends, and this is linked a little bit to the other question. What we have found is in a setting where we have more users in the hospital, that committee has less power, and I really do mean that. It tends to speed the process up. What we hold as part of .coms is all these data records, and what the hospital need is the information on the back end of our system. The more users we have in the hospital, the more incentive it is for that hospital to move quickly in the .coms, so they get the information from our back end into their medical record system.
Thanks.
Thank you very much, Susanna. Thank you so much. Thank you. We move to the next one. We are two founders still pitching. Moshe Leibowitz, CEO and founder of Healables. Moshe, please, the stage is yours.
Hi. Great to be here.
Welcome.
So let me share my screen here. So I'm Moshe Leibowitz, CEO and founder of Healables, wearables that heal. One of the best ways to create a solution that's patient-centric is for a startup to be founded by a patient. 15 years ago, I suffered a traumatic brain injury. And thank God I made a complete recovery with the help of traditional and mind-body medicine. What I learned on my journey of health and recovery and rehabilitation is that you need to treat the mind and the body together. And that's what we do at Healables. We treat the mind with our digital health coach, and we treat the body with our wearable electroceuticals. And that's Healables, wearables that heal. So what we do is we relieve pain, accelerate healing, and reduce inflammation without medication. So we treat with clothing instead of with drugs. First thing that I did was I recruited an amazing team. We're based in Jerusalem, Israel, and have access to phenomenal talent. Our chief medical officer comes from Harvard Medical School. Our CTO comes from Johns Hopkins. He's an electrical engineer as well as a behavioral health therapist. And our COO, CFO comes from the UK, from Leeds, and also spent international business in France as well. So chronic pain and sports injuries is a huge market. Those are injuries not just for professional athletes, but we all suffer from different types of sports injuries. One of the solutions that's used today is electrotherapy for physiotherapy, and it works really well, but it looks like this. So it's just not a usable solution. It takes a lot of time, and it's just not comfortable. Another electrotherapy solution, Merck has invested recently in an invasive implantable device for chronic inflammatory disease. So another great chip that works, but they're doing surgery to implant a chip inside of people's heads to reduce inflammation. We can do that with a hat instead of with the surgery. So here's our product for athletes. We have an electroceutical device that docks with smart clothing. Embedded in the textiles are permanent dry electrodes that deliver the electrotherapy and physiological sensors that provide real-time feedback. Together with our behavioral health coach in an app, we're able to profile a three-dimensional profile of an athlete, and then we're able to go and personalize treatment in real time to give them the precision medicine, the precision treatment that they need. And then for practitioners, we have a portal that allows them not just to monitor remotely, but to actually deliver treatment remotely. So you can have a practitioner in one city and a patient in another city, and they can give a hands-on treatment while being thousands of miles away. Our product pipeline takes us from our knee sleeve, which is our first product, to all different types of textiles for all different types of conditions. I also want to really focus on the two first verticals. Our first vertical is our wellness vertical, focusing on the sports market. This is not a medical product. Readiness, recovery, performance, soreness. that's what we're going for first. And then the second product line is a medical product with medical claims supported by clinical trials. So just a little bit about how it works. We're treating really in two ways, on mitochondrial health and on the whole person mental health. So with the mitochondrial health, what we're doing is we are shifting the mitochondria back from dysfunctional to functional by energizing with a microcurrent that helps to go and increase the ATP in the cell as much as 500%. And on the behavioral health side, we're able to go and shift the person from a stressed out state to a relaxed, calm state with our coaching. 64 users, we see that 88% reported pain relief of at least 50%. We have a worldwide patent portfolio on our electronics, on our digital health coach, as well as our design. Our platform technology can be applied to a whole variety of inflammatory conditions. So in the UK, we all know what rugby is. In the United States, I have to try to explain to people what it is. But what we see is that we have a pilot with the Stade Francais Paris rugby team, especially the lower limbs. We also have clinical trials going on in knee osteoarthritis here in Israel with the head of sports medicine. We have another trial written for diabetic neuropathy, and we are preparing a trial for lower back pain in India. In terms of our traction, we have an athlete, Avi Yosef, is a professional football player. He was out with a meniscus tear, used our device for 2 weeks, came back, played 20 minutes, and scored the winning goal. He's ecstatic about our product. And we have some medical traction with SRS Life Sciences. They're going to be distributing our product in India. So our roadmap takes us to all different types of chronic and pain and inflammatory issues, chronic pain, opioids, NSAIDs, musculoskeletal issues, respiratory, diabetic neuropathy. These all have a common inflammatory component that now post-COVID is becoming really front and center in the medical community. Our model is a 2/3 SaaS model, 1/3 device, with and that's both for B2C as well as B2B and B2B2C for the wellness as well as the medical side. So we're currently raising $5 million to expand our sports product launch and to go through clinical trials in multiple countries and to launch the medical product following the clinical trials and certification in the different countries. So Michael Jordan said, some people want it to happen, some wish it would happen, others make it happen. At Healables, we make it happen, and we're excited to work with investors that share this vision. So here's our product here. Here's an arm sleeve. We have our device that docks with our smart textile, and really excited about what this can do for people. So love to hear your questions.
Thank you very much, Mosa. Catello, if you want to start.
Yeah, so there's a clear need here, and I personally saw some of those opportunities, some also out of Israel. So you're right. One is the ergonomy, right, and the other is also the plus that you have with the remote control, plus the platform, right, for to check with these questionnaires how is going on with the athlete in this case and so on. In terms of validation clinically, right, speaking, right, the validation of your approach, do you have a plan that is going to give you enough data points to push this through an FDA clearance?
Yeah, absolutely. So again, our plan is to first go to the market with sports and wellness. And for the medical side, for the first trial that we're doing right now is an open label trial, but that's going to be followed up with an RCT. In India, our RCT in lower back pain is going to have about 100 people in each arm. So that should be enough to go and help to support a de novo, and which is what we want to do in the United States. And we're looking for relationships in the NHS, and every country has a slightly different classification and regulatory status. But in Germany, we like to go for the DIGA regulations, as for example. But the point is that because microcurrent is subsensory, and because we're tracking patients at home, it's relatively inexpensive to give to the people who can come to the hospital one time. get the device, and then we can track them at home and see if they're using it or not, while everything is completely blinded and randomized and de-identified. We're able to know, the people supervising the trial can know if it's being used or not, and it's subsensory, so therefore the sham treatment that we're able to deliver makes the clinical trial very cost effective.
Thanks.
Bruno.
Quick question about the sourcing of the various components. Is this being produced partly in China, partly Europe, US? How do you see that? And especially in terms of the scale up you anticipate in the coming years?
Yeah, that's a great question. It's being sourced from all over the world: United States, China, India, Turkey, Morocco, possibly. Israel. It's a challenging product to make because of the unique components that are required on the material science, on the electronics. Thank God we were able to put all the pieces together. And it's a great product. I think that part of the marketing plan, there's a lot of grants worldwide for local manufacturing, is to do parts of the manufacturing locally in the different countries that we go into. So we might do some manufacturing in Wales, for example, in Morocco, and in Turkey, and in some different, in India, in China, of course, and have the product will have a slightly different business model because of the differences in regulatory in the different countries, and probably local manufacturing as well.
Thank you.
Thank you, Mohsen. Thank you very much. We move to the last one. Les, President, EMEA Knife Biomedical Europe Limited. Please,
Yeah.
Les, the stage is
You
yours.
saved the best to last, haven't you, Matt?
Always.
So let's start with sharing the screen. I'm going to go through a flow describing our technology and our product. What is it? What are the key words? What's the ask? What's the technology outline, so you can understand in simple terms what we're trying to achieve. I'm going to talk for a minute or two on enabling technology, because we think that this platform technology will get us into the digital health market in a big way. I'm going to explain a little bit about ISF for those of you who don't know interstitial fluid. There are some good things about interstitial fluid and some bad things that we need to talk about. And we'll talk about the serviceable market. This is all in a 5-minute rush, so bear with me, guys. This is what the little wearable device looks like. That's what it is. It's a wearable, digitally connected Bluetooth device that sends data to your smartphone or your smartwatch. We can access 3,000 plus clinically important biomarkers non-invasively. 25% of the population hate needles in the sight of blood. So we're on a no nurse, no needle track. The founder is a pretty genius level guy called Dr. Abdeltif Eselek. He's one of the world's top biosensor scientists. He's been working on this for about 6 years, and he's created a lot of very strong patents around the technology. So it's a wearable. What are the key words? Basically, we're seeking a trade sale. The big guys, Amazon, Google, Microsoft, Apple, are interested in technologies that can get them into digital healthcare, and we think that this can do it. As I've said, it's strong IP. It would be very difficult for them to get around the IP. The vision is probably one per household. Like you've got a thermometer, why don't you have a way to sample stuff and send it to the doc? We'll talk about interstitial fluid. It's certainly a wearable. There is a large serviceable, obtainable market. It's an enabling technology, and it'll apply in consumer health to the guys we class as worried well or weekend warriors. So what's the ask? At the minute, we've had about $3 million in seed funding. Our Series A round is raising $10 to $15 million. We've got a pre-money valuation of $100 million. We've got 1.9 million in so far, and we're in NDA stage discussions with about 8 different investor groups at the moment. So what is the technology? It's basically a low voltage field applied to the skin, which opens up the pores, and then we put a low negative pressure on it to drain ISF up into a sample container. Once the sample container is in the wearable, you can either analyze it in situ with a biochemical monitor, or if it's a complex assay, you send that off to the lab. But you don't have to go to the clinic. You don't need a nurse. You don't need a needle. So it'll be interest to the pharmaceutical guys, clinical research, frontline clinical practice, ties in with telemedicine. individual care, sports medicine, consumer health, and even animal health has uses for it as well. So that's the technology. Why is it an enabling technology? The example I like to use is which came first, the elevator or the high rise. If Netflix has been wonderfully successful, it's only because a lot of houses have high-speed broadband to allow their streaming services. Kific will enable biofluid sampling at home to tie in with telemedicine and digital health, and I expect to replace at least 50% of all the blood tests within 5 years. So what is ISF? It's a clear straw-colored fluid that runs between all the cells of your body. There's about 21 liters of it compared to 5 to 8 liters of blood. As I've said, we've got 3,000 clinically useful biomarkers in the ISF. It's actually well researched, but it's never been used in frontline clinical practice because it's been too hard to access the ISF. If you use interstitial fluid for some of the assays for very small amounts, it gives you a better signal to noise ratio, so you can get clearer indications of the amount. But I'm actually going to say that some of the applications we're going to go for, they don't need to know absolute amounts. They just need green, amber, red. So imagine in the next pandemic, you put this device on, it looks for the pathogen, and if you're clear, it goes green, you can go to work. If it goes red, it will transmit that result to the government, whoever wants to do it. So there's a lot of things we can use the ISF for. The drivers are staff shortages. There's too few nurses. A lot of them are retiring age 55 with bad backs. Telemedicine reduces the number of clinic visits. As I've said, trypanophobia, fear of needles, affects at least 25% of the population. There are payor drives to do cost reductions. So if we take the operational costs of nurses and clinic visits out, we'll reduce it. We'll also do right sizing for healthcare delivery. Population screening for earlier diagnosis, particularly in the silent killers like ovarian and pancreatic cancer, can be done with this technique. I've said pandemic, we need to educate folks. Adoption challenge is the biggest problem we're going to face. How do we move people off the established blood sampling and put them onto ISF? Well, there's lots of things we can do as actions. The more money we get, the quicker we'll achieve that. So our initial product will be continuous glucose monitoring. Why did we choose that? They're an established market of 2 billion, dominated at the minute by Abbott and Medtronic. They use invasive ISF sampling. We're non-invasive. We can do the technology quite easily. Our founder, Dr. Abdelatif Esselek, knows how to do that. Means an easier FDA 510K predicate exists for us. We get down that route. And there's lots of distributors looking to compete in the blood glucose market and take away from blood sampling and substitute ISF sampling. So I'm nearly at the end. I just wanted to bring up something you probably already know. There's big tech are already looking into healthcare in a big way. Apple, Alphabet, Microsoft, Amazon, Facebook, it's all examples online where you can see where they bought companies already. The serviceable market is 500 million blood tests per annum in the UK, 7 billion tests per annum in the USA. We've got to get a proportion of that. We've got to get our technology out there. And then other companies will come in and develop uses for interstitial fluid for their particular segment of the market. I've tried to be as quick as I can, Max. So that's the end of my slide show, and I'm back live.
Thank you very much, Les. Bruno Catello, if we want to close.
By questions, yeah, just a quick question for me. It was not necessarily clear. What clinical trial have you done so far for which application?
We have no clinical trials completed. We need the funds to do that properly. We've got some human volunteer studies, but I wouldn't call them a clinical trial, Bruno.
Okay, thank you.
We know we can generate the ISF, yeah, but we haven't actually gone in. We've had some hospital use to verify that ISF levels can be measured, biomarker measures levels in the ISF can be measured as they can from the same subject in blood. So there's a little bit of a crossover there, but that's not a clinical trial.
Catello?
Yep. I mean, do you foresee any issue in supplying the component for your technology?
We've engaged a professional R&D company to help us through that. There are some engineering challenges, for example, making sure we've got biocompatibility between the vacuum device and the skin, making sure the battery lasts long enough. They're engineering challenges. That's not what I foresee as the biggest one. The biggest one is we need to put enough money into getting the key speakers to say ISF is the best thing you can do, measure ISF, not blood. So the adoption challenge for me is bigger than the engineering challenge.
Thanks.
I've done that before, by the way, with a company called KCI when we were getting VAC into the wound healing market. I don't know if you know VAC or not, vacuum assisted closure. Everybody said, just stick a bandage on it. We came along and said, no, here's a mechanical device that's going to speed it. It was an education process to go through. We got through it, and now it's a multi-billion-dollar company. So yeah, I've done it before.
Thank you, Les.
Okay,
We've been
guys.
around a little bit late. We are 10 minutes late. Unfortunately, we can't take any Q&A because we had to close at 7. We already 7:10. But please, if you want to be in contact with our founders, come to get in contact with us, pitch@equitymatch.co, or message here to our team, and we introduce our founders to anyone who wants to talk to them. I really thank you very much. Thank you so much, Catello, Bruno, for being with us. It's been a huge pleasure for me. Thank you all our founders to come with us and take the time to pitch in our event. And I see you again the 21st and 28th in April. We have the 21st, we have the panelists in Impact, and a week after the pitch day, always in Impact. Thank you very much to everyone, and I'll see you next time. Thank you.
Thank you. Bye.
Thank you. Take care. Bye.